Hi everyone. So I will be discussing the short dental implants. So I'm Dr. Abhin Miglani. So we will be discussing this in an elaborative way. So this will be a long presentation. So we will be discussing when, where, how, success, and literature of the short implants in detail. So I will be including many articles in this to make this explanation a little more easier for you. So, coming to the introduction, so the longer implants were thought to distribute the loads more efficiently since they would provide a favorable implant to crown ratio. However, in certain clinical situations with major anatomical limitation, such as the maxillary sinus pneumatization or reduced alveolar bone height as a result of tooth extraction, placing longer implants is not always a straightforward procedure. In relation to the location, posterior areas of both maxillary and mandibular arches demonstrate lower bone quality and quantity than the anterior areas. Anatomical structures such as the inferior dental nerve and the maxillary sinus may further limit the existing available bone to the implant insertion site. So basically, we will be discussing that the longer implants have, although they have a more implant to crown ratio, but in all the clinical scenarios, it might not be possible to place the longer implants because at some cases, like when the maxillary sinus has pneumatized or in the mandible, when there is a reduced alveolar bone due to bone destruction above the inferior alveolar nerve canal, there might be a possibility that we require to place a bone graft before a implant placement procedure. That might not be feasible in all the cases, maybe due to economical reasons or the patient cooperativeness. So basically, the short implants, as short implants can be classified into three types. So according to the classification, there were different classifications. So first of all, in the year 2000, Freeberg et al. Defined short implants which are 7 or less. Then came the Griffin and Cheung in 2004, who described the short implants as those implants which were less than 10 And then came the Renard and Nisand in 2006, which declared that the implants were less than 8 were to be referred as 8 to be referred as short implants. But now, according to all the recent classifications I have read till now for you people, so I have seen that 7 to 8 decided finally as the length of short implants, and the ones which were less than 7 were described as the extra short implants. I have included both the short implants and extra short implants in this PPT. So then, coming to the classification of the implants on the basis of width. So usually these short implants need to be wide, so to as to compensate the bone to implant contact, as the longer implants provide a more bone to implant contact to overcome any kind of disadvantage or contraindications. There should be a higher bone to implant contact. So since the length is less, so a wider implant is usually preferred to increase the success rate of a short implant. So according to implant width, the short implants can be classified as the wide implants with the diameter of 4.5 or more, and narrow implants with a diameter of less than 3.5 And this was given by again the Renard and Nissan in 2006. Then why short implants? So developed to minimize the need for bone grafting, used in areas with limited bone height, reduced surgical morbidity and faster recovery, effective even in atrophic jaws. So the areas with limited bone, so the height of existing bone like maxillary sinus and mandibular canal, as discussed earlier. Then the situations which limit long implant usage, like the history of chronic sinusitis, allergic sinusitis, cystic fibrosis, pathological lesions, patient's acceptance for adjunctive surgical procedures for placement of long implants. Then we can classify the implant sites as class A, class B, and class C. Class A being more than or equal to 8 class B with 4 to 7 which requires minimal grafting, and class C less than 3 which definitely requires grafting. Then coming to the implant design and technology, the modern short implant features enhanced surface treatments, locking tapers, subcrestal placement options, platform switching for better bone stability. So, what is a platform switching? You might be thinking of. So basically, when the abutment over the implant has a narrower diameter as compared to the implant body itself, it causes a reduced inflammatory response on the crestal surface of the implant margin or the bone margin, which increases the success rate of the implant by decreasing the peripheral or the marginal bone loss, which occurs even uneventfully every year. And coming to the advantages of short implants, it enhances the patient willingness and comfort, minimizes the number of surgical interventions required, it reduces the overall treatment expenses, lowers the risk of complications, and speeds up the recovery and rehabilitation process. Coming to the indications of short implants, they are same as the traditional implants, but those cases uh, have to be discussed here, which require bone grafting, usually the posterior atrophic maxilla and the posterior mandible, where the proximity to inferior alveolar nerve canal is very less. Then coming to the contraindications, the absolute contraindications, मतलब कि हमें जहाँ पर इम्प्लांट्स नहीं लगा ही नहीं सकते हैं, जैसे अनकंट्रोल्ड डायबिटीज, इम्यूनोसप्रेशन, रेडिएशन टू जॉ बोन्स, active bisphosphonate related necrosis, and severe systemic illness. Then coming to the relative contraindications, जहाँ पर हमें लगाना तो नहीं चाहिए लेकिन लगा भी सकते हैं, अनलाइक द एब्सोल्यूट कॉन्ट्राइंडिकेशंस जहाँ लगा भी नहीं सकते हैं, लगाना भी नहीं चाहिए, पुअर ओरल हाइजीन, heavy smoking, lack of bone volume, and adolescents unless the growth is completed. Then coming to the evidence of success, so I have marked all these authors in bold letters. So for the exam going PGs, so it might be the topics which need to be written in the exam to get you better marks. So Ewers et al. In 95.6% success in grafted sinuses. Freeberg et al. 7 implants had similar outcomes to traditional implants in partially edentulous jaws. Studies show that the short dental implants, that is about 8 long, have a high success rate with about 91.4% still working well after several years by Busser et al. In 1997. Then coming to another study by Freeberg and the team found an even better success rate with 95.5% of 95.5% of the implants lasting at least 5 years. Then coming to the clinical applications, the posterior maxillary and mandible incisive canal region, cleft palate rehabilitation, tumor resection cases, the narrow ridge cases so the short or narrow implants with 3 to 3.5 diameters are used in mandible incisor and maxillary laterals region, usually when the maxillary laterals are congenitally missing and mandible incisors are already very small teeth, so there is usually requirement of short or narrow implants. So, coming to the sinus lift and short implants, then minimally invasive sinus lift can be combined with short implants, which reduces the need for lateral window sinus grafting. So, basically, whenever you operate, whenever we are inserting any sort of a graft, any sort of a bone graft material, or any foreign substance, there, no matter how better is the quality, from where, which country have you imported it from, how expensive is it, whenever you are opening any sort of area inside a human body, there is always a risk of complication, which is directly proportional to the amount of surgery you are performing. So in this case of short implants, we are focusing how to minimally restore the function and aesthetics of the patient which have a missing teeth. So the sinus lift and short implants. So minimally invasive sinus lift can be combined with short implants. It reduces the need for lateral window sinus grafting. Then coming to the short implants versus bone grafting, the short implants avoid the need for complex grafts, quicker treatment, less morbidity and cost, comparable outcomes. And the Brainmark legacy, that these are the, these were the Brainmark implants of 7 mm, so which were used in edentulous jaws. So short implants are critical for patients with high resorption. So coming to the Straumann short implants, so these were the implants 4.1 into 4.8 mm, 4.8 into 6.5 mm, which had a proprietary designs for increased stability, proven long-term outcomes, and used widely in clinical practice. Then bone to implant contact importance. So the shorter implants benefit from high bone to implant contact, mostly due to high ear diameters, as discussed earlier, precision fit abutments, reduced implantitis risks, and future of and it has a future of antimicrobial coatings, and many implant companies have started producing the implants with antimicrobial coatings. But then coming to the biomechanical considerations, so the crown implant ratio is critical. Short implants work well with splinted prostheses, and proper angulation and positioning is essential. Then coming to the ultra short implants, so basically the implants which are less than 6 mm, as discussed earlier. So all the ultra short implants are types of short implants, but not all short implants are not types of ultra short implants. So it's used in cases with very limited bone success, similar to the traditional lens with proper protocols. Clinical case of incisive canals. So the implants placed in incisal foramen, minimal nerve complications, effective anchorage for maxillary anterior restorations. So here in this right side, you can see the steps of how the short implant was placed. Then coming to this case study of a cleft palate patient whose repair was done, cleft palate repair was done, and then short implants were used to restore the dentition. And customized trachea bridges for aesthetics and function. Long-term success were reported. Then tumor rehabilitation cases also can be used. Short implants in atrophic jaws, so used when ridge height and width are insufficient. Avoids invasive grafting techniques. Minimal complications. Implied implant site planning. CBCT essential for evaluation. Guided surgery ensures precise placement. Digital workflow enhances the outcome. So in this right side, this is the CBCT images, and first has the OPG image. So for the planning of the short implants, coming to the restorative considerations. So the restorations must accommodate for height and position. Zirconia preferred for aesthetics. Crew retained process favored. Then long-term outcomes. So the study shows success of more than 90% over 10 to 15 years. Proper case selection is vital. Maintenance critical for longevity. Coming to the review of literature. So I have added 7 to 8 articles in short explanation, and two major articles. And two major articles I have presented as a journal club here. So those are both in detail. So this is the first article of 2025 in International Journal of Implant Dentistry. So its title was that clinical and radiographic outcomes of extra short implants, that is less than or equal to 6 mm, in the posterior atrophic jaws, a retrospective cohort study by Sevolella et al. So this study evaluated extra short implants, dental implants of less than or equal to 6 mm placed in the patients with severe bone loss in the back, that is the posterior jaws. It assessed the implant survival and bone loss over 5 years, also analyzing the effects of different loading protocols, that are immediate versus delayed, and use of intermediate abutments. Overall, these implants showed good survival rates and minimal bone, supporting their use as an alternative to bone augmentation. So I have written this in detail. Wait, let me explain you. So basically, the extra short implants, according to this study, less than or equal to 6 mm in length, implants are used. Uh, so it was seen that they can be easily used as an alternative to using longer implants in combination with the bone augmentation like sinus lift or guided bone regeneration in atrophic posterior jaws. So the key inclusion criteria was that more than or equal to 18 years old patients with American Anesthesia Society Association class 1 and class 2, having single or multiple maxillary and mandibular molars or premolars associated with alveolar bone atrophy, available bone height between 6 mm to 8 mm, width at least 8 mm, Then yeah, exclusion was the untreated periodontal disease, need for bone regeneration, chemotherapy and radiotherapy, and anti-resorptive drugs. Then the primary objective was to check the implant survival rate and the marginal bone loss, and the impact of loading. There was a comparison between conventional and intermediate loading as well between the short implants. Then coming to the study design, so it was a retrospective cohort study with the long-term outcomes of implants already placed between 2013 and 2022. 56 implants were placed in 34 patients, the 12 males and 22 females with a median age of 63 years. So there was 6 cases out of 56 cases, out of which 4 had occurred in a patient in periodontitis, which were failures. So then coming to the to the overall 5-year implant survival rate, it was 89%, and the implants with conventional loading had a survival rate of 87%, while the implants with immediate loading had a survival rate of 94%. So immediate loading didn't reduce survival in this cohort. Then coming to the mean marginal bone loss, so it was 0.14 mm at 1 year and 0.25 mm at 5 years. So then, then how did the authors measure marginal bone loss and marginal bone level? So standardized periapical radiographs were taken at the rate place at the time of placement, loading, 1 year and annually. Radiographs were calibrated using known diameters, and marginal bone loss was measured from implant shoulder to the bone crest. Negative values indicated loss, while the marginal bone loss accounted for initial vertical position of implant relative to the shoulder. Then coming to the why intermediate abutments be associated with reduced marginal bone loss. So the intermediate abutments create a vertical platform switching effect that may stabilize the supracrestal soft tissues and reduce the implant impact of micro movements and micro leakage and implant abutment interface. Then the immediate loading was there with the provisional resin crown placed on the same day, and width of the implant used was 5 to 6 mm, and all prosthetic components had 4.1 mm diameter. So now coming to the next article in my review of literature. So this study was clinical outcomes of short dental implants supporting prosthesis in the posterior region by Hirani et al. So this study focused on short 6 mm implants placed in the back premolar region of the jaws to support different type of prosthesis. Over a 2-year follow-up, these implants showed high survival rates and minimal technical complications, suggesting they are reliable option even without bone augmentation. Then coming to this another article. So this was an article in Quintessence International in Berlin, Germany, 1985 journal. What was published in March 2014. Then the title was as follows: The Short Dental Implants, an emerging concept in the implant treatment. So this review highlights the use of short implants as an alternative to more invasive bone augmentation procedures, especially in cases with limited bone height. So it concludes that modern short implants less than 10 mm. So basically, all the studies I have seen have taken their definition of short implants as different. So for literature point of view, for your knowledge point of view, I have written the 7 to 8 mm as short implants, taking out the mean of all the articles I have studied till now, and less than 6 mm as the ultra short implants. Okay, so then coming to the another article, outcomes of treatment with short dental implants compared with standard length implants, a retrospective clinical study. So retrospective clinical study. So the I've mistaken one thing before that. From 6 to 8 mm can be considered as short implants. Less than 6 mm is usually seen in the studies as the extra short implants. So, sorry for the mistake. So, this article, outcomes of treatment with short dental implants compared with standard length implants, a retrospective clinical study by Burzi et al. In the EA 2024 in Maxillofacial Plastic and Reconstructive Study. So, this retrospective clinical study compared 8 short implants with standard more than 8 implants. The study found no significant difference in success rates, marginal bone loss, or probing depth, suggesting short implants are a viable alternative. Then coming to the short implants, when, where, and how, by Anjan Kumar Shah, Department of Implantology, Raja Rajeshwari Dental College and Hospital, Bangalore, Karnataka. So this was a paper which reviewed the indications, success rates, and biomechanical considerations of short implants. It emphasizes that the short implants more less than or equal to 7 can replace the need for complex bone augmentation in cases of severe bone loss, provided proper planning and techniques are used. Then coming to my own article, so this was a review article in the Journal of Research in Medical and Dental Sciences to year 2022, with my guides Dr. Apurva Mishra and Dr. Rajnikant Kambala at Department of Oral and Maxillofacial Surgery, Sharad Pawar Dental College during my internship. So this review summarizes evidence on the effectiveness of short implants, commonly less than 10 as a simpler alternative in atrophic jaws. So it points out the success rates are generally high and comparable to standard implants if certain biomechanical factors are addressed. So this was an article in 2012 by Esposito et al. The posterior atrophic maxillary of posterior atrophic jaws rehabilitated with prosthesis supported by 6 long, 4 wide implants or by longer implants and augmented bone. So a short-term data 5 months after loading indicate that 6 long implants with a conventional diameter of 4 achieved similar result to longer implants placed in augmented bone. Short implants might be a preferable choice to bone augmentation since the treatment is faster, cheaper, and associated with less morbidity. 5 to 10 year post loading data are necessary before making reliable recommendations. Then, coming to the clinical oral implants research journal by an article of 6 versus 11 lens by Gulje et al. You can pause this video and read this. Then coming to the clinical implant dentistry and related research 2012, rehabilitation of the atrophic posterior maxilla using short implants or sinus augmentation with simultaneous standard length implant placement, a 3-year randomized clinical trial. You can read this article. Then I'm presenting my first major article, the lateral augmentation of the sinus floor followed by regular implants versus short implants in the vertically deficient posterior maxilla, a systematic review and time-wise meta-analysis of the randomized studies. So it was an article by Grunau et al. In the year 2023 in the IJOMS International Journal of Oral and Maxillofacial Surgery. So the lateral, first of all, we will be discuss what is a lateral approach for sinus augmentation. So according to definition, a surgical procedure performed to increase the vertical height of bone in the posterior maxilla by lifting the Schneiderian membrane via a lateral wall window and placing graft material to enable future implant placement. So its indication as per MIST fourth edition was the residual bone height less than 5 severe atrophy of posterior maxilla, anatomical limitations, for example, pneumatized sinus, simultaneous or staged implant placement requiring adequate vertical bone height, lateral approach. You can see in this diagram, the lateral approach for sinus augmentation were included. Osteotome sinus floor elevation was an exclusion criteria. Then coming to the aim of the study was to perform a time-wise meta-analysis of randomized control trial comparing the outcomes of short implants less than or equal to 6 versus lateral sinus floor augmentation followed by regular implants of more than 10 in the deficient posterior maxilla. So there were 11 RCTs with 1, 3, and 5 years of follow-up. Then this PICO criteria with the partially edentulous and posterior maxilla and vertical bone atrophy. Then the short implants of less than or equal to 6 mm. Then the C had the lateral SFA plus regular implants of more than or equal to 10 mm. Then the O had the outcomes that had the survival complications and bone loss osseointegration were included for the outcomes. Then in total, 11 RCTs were identified through the literature research. Then 218 records are identified. So you can look for all this by pausing this video. Then coming to the methodology, this PubMed hand search and cross referencing was done. 11 RCTs were taken. Inclusion criteria for short implants. The patients or cases appropriate for short implants typically included inadequate vertical bone height, less than 10 mm of bone available, patients unwilling or medically unsuitable for bone grafting or sinus lift procedures, atrophic posterior maxilla or mandible, elderly patients, or those with systemic conditions where minimally invasive procedures are preferred, patients requiring immediate restorations in compromised bone volume situations, posterior areas with reduced anatomical availability, maxillary sinus proximity, and inferior alveolar nerve. Then coming to the exclusion criteria for short implants. So the situations were where short implants are contraindicated or less advisable, like severe bruxism or parafunctional habits causing excessive occlusal loads, poor bone quality, that is with type 4 bone, especially in posterior maxilla without splinting, insufficient interarch space for proper prosthetic height and crown implant ratio, cases where adequate primary stability cannot be achieved, uncontrolled systemic diseases, for example, uncontrolled diabetes, recent myocardial infarction, active infection at implant site, or history of osteomyelitis, patients with poor oral hygiene and compliance. Then the results were that the implant survival rate, no significant difference in implant loss at 1 and 3 years between the short implants and regular implants with sinus augmentation. After 5 years, more implant loss was noted in the short implant group, approaching statistical significance with a p is equal to 0.06. Then comparison with previous meta-analysis, the past studies by Chavare et al. Showed no survival difference but did not group data chronologically. This study's time-wise analysis reveals a potential trend following regular implants with augmentation over longer periods. Then the ultra-short implants with 4 mm had two RCTs examined. The both showed no difference in survival rates at 1 year when compared to regular implants. So coming to the perioperative complications, so this data was on perioperative complications were extracted from 1 year follow-up reports of 10 studies for meta-analysis. Only biological complications included, not mechanical implant complications. Three times fewer complications in the short implants group, excluding ultra-short implants, compared to regular implants with augmentation. This difference involved biological perioperative complications only. Then coming to the marginal bone resorption. So short implants consistently showed less marginal bone loss than regular implants. So the meta-analysis of the marginal bone resorption in each trial showed a significantly lower bone loss for short implants after 5 years when compared to regular implants with augmentation. So these were the difference increased over time. So then coming to the residual osseointegration length, after 5 years, short implants had a or residual osseointegration length of 3.35 to 5.88 mm. The regular implants had 10.1 to 12.54 mm. Longer implants are more resilient to minor bone loss, reducing implant failure risk. Then the patient-centered considerations, short implants were less invasive, lower cost, reduced treatment time. Then coming to the complication risk with augmentation, no statistically significant increase in complication rates with augmentation procedures. So the residual osseointegration with the regular implants showed 6 to 6.5 mm greater osseointegrated length, advantages in inflammatory bone loss situations, important factors for long-term implant stability. The residual osseointegrated implant length is responsible for anchorage of the dental implants to the bone. Then the strengths and limitations were the strengths of the study was a time-wise meta-analysis design. focused comparison on vertically deficient posterior maxilla, strict inclusion criteria, comprehensive outcome assessment. Limitations were that heterogeneity in augmentation materials, short to medium term follow ups, then the comparative meta-analysis and systematic reviews, the cross-article references. So the vertical bone augmentation and regular implants versus short implants in the vertical deficient posterior mandible. A systematic review and meta-analysis of the random studies by Terheden et al. In the deficient atrophic posterior mandible, short implants and regular implants demonstrate comparable outcomes with the five first years. Then another article by Cruz et al. By short implants versus longer implants with maxillary sinus lift, systematic review and meta-analysis. So this had the short implants placement is an effective alternative because of fewer biological complications and similar survival and marginal bone loss and long implant placement with maxillary sinus augmentation. Then the conclusion was that this systematic review and time-wise meta-analysis compared short implants less than or equal to 6 mm with lateral sinus floor augmentation followed by regular implants more than or equal to 10 mm in the vertically deficient posterior maxilla. 11 RCTs with 1 to 1, 3 and 5-year follow-ups were analyzed. At 1 and 3 years, implant survival rates were similar between both groups. After 5 years, a trend favored regular implants with augmentation. And as this, we have discussed everything of this earlier. So in conclusion, short implants offer comparable outcomes to regular implants with augmentation within 5 years. Then this is my second major article, the clinical and radiographical outcomes of extra short implants in the posterior atrophic jaws, a retrospective cohort study by Sivolella et al. I had discussed this article at the first one where I was reading from this sheet. So I have added this in as a separate journal presentation in detail here. So just I will be reading this quickly. That what are extra short implants, clinical significance, research study design, the retrospective cohort studies, 5-year follow-up, 5 to 6 mm length implants are used, and focus was on survival rates and bone loss. So all this I have discussed in the first first review of literature article. So the two loading approaches were used, immediate loading and convention loading. So these all parameters were measured, the implant survival, marginal bone loss, marginal bone level, and the complications. The 5-year implant survival rate with 6 failures in a single patient, that too with the periodontal disease. Then coming to the survival rate comparison, 85% conventional loading and 94% immediate loading. Then coming to the implant failure analysis, that total failures six implants, primary cause peri-implantitis. Then I'm sorry that there were 4 failures in one patient at 2 years and two in other one. And the marginal bone loss at 1 year was 0.14 mm bone loss in minimal. At 5 years, 0.25 mm bone loss still minimal. And immediate loading impact was associated with more bone loss, and the intermediate avertment benefits reduces the bone loss significantly. Then coming to the what is platform switching. So I have discussed this as well earlier, that horizontal using a narrower abutment diameter, vertical using taller intermediate abutments result better soft tissue seal, less bone resorption. Then coming to the clinical complications, the biological 11 implants with mucositis at 1 year, progression 7 evolved to peri-implantitis, mechanical complications, 3 cases of screw loosening, and no implant or prosthetic fractures. Then extra short versus standard implants. So the standard implants had a survival of 96 to 98%, while the survival rate of extra short implants was 89%. So the standard implants require more bone surgery, more invasive, higher cost as compared to short implants. So coming to the clinical conclusion, so extra short implants are reliable for posterior teeth. Immediate loading can be successful, and bone loss remains minimal for 5 years. Intermediate abutments protect bone. Clinical recommendations: how and loading and follow will be discussed in the clinical recommendations. So consider for atrophic posterior jaws, how use platform switching approach. Loading, immediate loading is viable option, and follow up, close monitoring of gum health is crucial. So this last article of my of my presentation. So this was an article by Mauricio et al. That is the failures in single extra short implants less than or equal to 6 mm, a systematic review and meta-analysis. The risk of failures of crowns supported by extra short implants is similar to those supported by conventional implants, regardless of previous maxillary sinus augmentation or follow-up period. The most frequent biological and prosthetic complications of bleeding on probing and abutment failures, respectively. Thank you.